So wounds are divided up into the surgical, non-surgical, acute, chronic. Wounds all have a different etiology. Some have mixed etiologies, whether they're full thickness, partial thickness when you're describing them. And then it goes into not all wounds have a stage. Pressure ulcers are the only wounds that are staged. So you want to make sure that you're not staging a skin tear. You can classify a skin tear, so it's just the wording, but that wording becomes very important in reimbursement for the product. So, and also in the regulations and whether or not you stage something as a pressure sore and it's not a pressure sore, it wasn't present on admission, now we're calling it a pressure sore, and now all of a sudden we're starting to get docked with money on the inpatient side. So the type of wound and how we're describing it in the classification, stage, grade is important, specifically for reimbursement in the regulatory world. I'm going to hit a little bit of that as well. Did it move forward?
Yeah.
Okay. Well, this is a little confusing, having that little
Yeah.
box off to the side. So the things that we're probably more familiar with here at Prairie are our arterial, our venous ulcers, probably see the neuropathic ulcers, some with our, because there's more diabetes out there than ever. The mixed etiology wound is that wound where you're seeing a venous and arterial component both. They call those mixed. Then the surgical wound that has failed to heal, skin tears, trauma wounds, we see a lot of those. And then that other category, and that other category is bigger than you think that it would be out there, and those seem to be the most complicated wounds to try to heal up, is that other category. And those are your autoimmune kind of conditions. So in chronic wounds, your most common would be your pressure, followed by venous, diabetic, arterial, and then acute wounds that fail to go on to heal. So that would be that surgical wound or skin tear in someone who has venous stasis disease. They got a skin tear on the leg. It was a trauma, so it's acute, but they have severe venous stasis disease and the wound just will not go on to heal. When you have somebody who has an acute wound with, on their lower extremity, it's diabetes, and diabetic or venous disease, if they haven't healed in the first 2 weeks, they're showing really 50% reduction in that wound, go ahead and they need to be sent to the wound center, because that person is set up automatically because of the conditions that they have. They're not going to heal in the normal process. It's not going to be an orderly fashion. Then the acute wounds classified as your surgical wound. They're sudden. They move rapidly through the predicted wound healing phases. Your burns and your skin tears all should be healed up in 4 weeks, depending on the size of the wound. But within 4 weeks, these should be resolved. Most of these are from interruption in blood flow. The blood flow initiates the clotting cascade, releases the growth factors, and then goes on to release the healing cascade where everything matures. You have reepithelialization. These wounds can be partial or full thickness, and the full thickness wounds may take longer than 4 weeks to heal. As long as they don't have any other comorbidities, by 8 weeks it should be completely resolved and have, you know, a tensile strength that's pretty sustainable. In our chronic wounds, your tensile strength, you know, you're healing by scar, secondary intention. It takes 2 years for the tensile strength to get back to 80% of what God gave us.
What is tensile strength?
It's the strength of the tissue, of how quickly it could break down again.
Oh, okay.
They don't have good tensile strength.
Gotcha.
You know, I mean,
Yeah.
they could just, it can come
Comes
apart
apart, yeah.
easier. So one of my first nasty pictures, it's really blurred up there, and I'm kind of glad. If you have it up on your screen, it's pretty clear, but I don't know if there's a way to turn the light down so everybody can see it, or is it clear on your photo in your, because I just kind of wanted to hit some, that's better. When you see a wound and you're like, oh, I want to say what's going on in that wound, identifying, you know, granulation, even if you do, you know, the wound, you know, is 75% granulation, and 25% necrotic slough. So you've got your necrotic slough at the top, you have the granulation at the bottom, wound edge erythema, you can see that out around. Your induration is just that firmness along the wound. And as I'm a very touchy-feely person in wound care, so I am feeling the legs, and it's like you can go right up and about that far out from the wound, you like hit this barrier of firmness. That's induration. And then maceration is when something has been wet too long and you get that white washed out look. So that's an indication to me that I need to make some adjustments in my treatment plan when you start seeing that. Need something to absorb wick a little bit more. So this is my wound algorithm that I use for my nurse practitioner practice, and when I need to, consult my collaborative. In Illinois, I guess we don't have to have collaborative now, but I still like my resources in the clinic and still pull upon them. So, patients are coming in, I'm identifying what I need to do in my workup. If someone's referring a patient in, if one of you are referring somebody over, I'm like, hey, these are the things I need. If I have them before they get here, it's even better. So for us being, a vascular focus, having that patient already set up for the vascular studies, ABIs, toe pressures, those are easy. If, you're sending them over for lymphedema, it's really important for me to have that most recent echo, for us to have the most recent, if they have issues with heart failure, what's the BNP running, how are they fluctuating, what kind of a shift can they tolerate in the BNP, and then monitoring that as we go along. Our x-rays, if we have if there is an ulcer over a bony prominence and it's been there for 4 weeks or more and they haven't had an x-ray, I want an x-ray. I want a baseline x-ray because I'm looking to make sure that person doesn't have osteomyelitis. First x-ray may be fine. 8 weeks, this wound still isn't healed. I send it back in and I've got changes on my x-ray. So that's part of standard of care for us. Some people say, if there's not signs of infection, why are you culturing? I will culture even if I don't have frank signs of infection. If I have a wound that's failed to heal, if I have a wound that's got just a lot of hypergranulation tissue, it's wet, or they're complaining of pain, I will go ahead and do a culture and see what's going on. Sometimes I have a bile burden that's not allowing the wound to heal, and so that culture will let me see, okay, what's my best topical that I can use? I might want to put them on a gentamicin powder. It might not be something I need to treat systemically, but maybe I need to be treating what's there on that wound. So if it's Pseudomonas, maybe I need to do acetic acid on that. If it's MRSA, maybe I need to go ahead and do a Dakin's solution for 2 weeks. So I will use that culture, not because of systemic necessarily signs of infection, but okay, how can I manage this best locally? Because we have a lot of products that will say, this product is good for this bacteria of the wound, and just using that topical wound dressing as an antibiotic for 2 weeks, I could reset that wound and get it back to a progression of wound healing.
Can you just go over, so when you're doing the culture, are you using like that double-tipped?
Well, mine are single over there. Mine are the ones that are provided by the hospital.
Okay.
So it's just the regular culture and sensitivity tube.
Okay.
Is what I use over there. We clean the wound well. I usually don't like to culture until after I've debrided the wound, flushed it with saline, and then I will put the culture down into the wound bed, put pressure, and actually spin the culture and hold it there for a little bit to where it pulls up fluid from within the wound. I don't just through the wound and get the goo.
That's how most people do it.
Yeah, no. I mean, so my cultures, I feel confident in what my culture is showing, so that I can make a decision on, okay, is this somebody that's got I've done, a proper wound bed preparation to obtain that culture, and I've got a polymicrobial result on my culture. I've got 2 ID specialists in the wound clinic. I'm gonna tap this person into their clinic the next time and see why I need to do something different. So that's the benefit of having that multidisciplinary team down there. And everybody being on different days. It's like, okay, I saw him today, but I saw a person on Thursday and got a culture report back. I'm like, I really want you to come back and see ID on Monday, And they're like, oh, well, where do I have to go to vet for that? I'm like, right here. And they're like, oh, okay. So that it's very beneficial. And we work as a team. We'll flip people back and forth depending on what they need. If I seem to get all the pressure ulcer needing offloading, or the lymphedema legs are like, Nancy, you need this person. I'm like, okay, well, you need this one. I'll trade you. You know? So we move them back and forth. So early on in wound care, I like to see people evaluate them in a week. If it's somebody that's been on a plan, we've got it established, we're showing progress, but it's going to be slow, I will bring them back in 2 weeks. And that's acceptable. They always know if there's a problem in between, they're calling and getting back in. So additional testing, ultrasound, the bone scans, CT, CTAs, the MRI, MRAs. Generally, when I'm getting to the CTA and MRA, I'm sending those on to vascular. You know, it's like, yeah, I think this is what they need. I can order it, but I want an appointment already set up with vascular when I'm needing to get those type of testing done. And then going on to wound types, we used to raise and show bull mastiffs, and this is Attila. And this, when I got this picture, I'm just like, oh my gosh, this is definitely the way to offload pressure and keep yourself warm is, you know, sitting on ladies. So I included that in one of my presentations. I'm like, oh, I'm going to leave it in for this one. So are you guys comfortable with staging and pressure ulcers? If you are, then I'm going to breeze through this, because I think maybe focusing on the dressings may be more of what you guys are wanting to do. And I don't want to cover stuff that we're doing all the time. So I would like to, I don't know if there's a way for me to pull up just this one. And I can't. So stage 2, both are butts. Both are butts. But what I want to point out,
There's a finger on this little remote right here.
is this is something you guys might see, and you're like, which is the laser?
Yeah.
This here, this is somebody who sits too long, who's overweight. That's venous congestion. Those are like varicosities in the bottom right here. And this person has lots of external hemorrhoids too. They're just, you can't see them because I didn't separate the cheeks. But when you see people like this, they gotta refer them to physical therapy, get them up and get them moving. Because, you know, it's from them sitting too long, and they're like, oh, I'm on a pressure relief cushion. Well, what cushion are you on? I'm sitting on a donut. All that is just congesting right in that buttocks. So they need to be on a flat offloading cushion and get moving. And for these type of people, I will recommend, if the skin is intact, that they need to do just like a maintenance skin care. This is a copolymer film, and it's a skin barrier. It just helps provide just a little thin layer of protection on that skin. There's nothing open, but that will open really easily, and then these people tend to bleed. They're the ones that bleed all over the toilets. It's because of these venous. So I had another person come in that had them in the pannus, these big varicosities in the pannus and the bottom. So I'm like, well, if we can do venous ablation on the lower legs, why can't we do some venous ablation up higher, or some, so I actually refer to vascular for perineal varicosities. It's a thing, you can do it. So I'm like, why can't we do some venous ablation on these things? So I wanted to show that, just that, you know, the skin is intact. People are like, oh, those are pressure ulcers. Actually, they're varicosities. This is the stage 3 pressure ulcer. This one, if you're seeing this, this is just the bottom of that you don't want to see. You're going to see this mainly in the ICUs, in home care, people who are incontinent. This is a call to the woundostomy continence nurse. This person has candidiasis, they have a pressure ulcer, they have moisture associated incontinence. So plan for those. You got your offloading. I use the 2% miconazole dust crust it with 3M no sting. They need moisture management, foam dressing on the sacrum. You're not going to get anything to stick on the perineum, so you're going to be using barrier creams to those areas. So this is the one you never want to find. This stage 4 pressure ulcer, she was just in all whole system shutdowns. She'd had an amputation of a leg. It was not good. But this would be something I would vac. this person in the family opted for comfort care. The unstageables, you don't want to see these either. Interesting enough, the one on the left, that pressure ulcer came from being in ICU and not being able to be moved. Then on the low pressors, the sepsis, the whole, so that person healed up. Because they were a young individual, they just had a really bad health episode. And then the deep tissue injuries. This is a patient with diabetic. This is considered a full thickness wound. Full thickness wounds go to deep tissue. This person stepped on a darning needle. I didn't even know what a darning needle was until she didn't know she did it.
No.
Until blood was like dripping everywhere. It was through the foot. But it healed. We vac it with doctor debrided it, antibiotics, we vacced it, it healed. It was a young individual, but long time type 2 diabetic with peripheral neuropathy. So, usually there's deep tissue structure damage, heals by secondary intention. 80% of lower extremity wounds are made up either venous, arterial, or mixed disease. Those are our mainstay around Prairie. If it's arterial, stop, just refer it to the vascular specialist. We're not gonna wet them, we're gonna wanna dry them up, so it's basically betadine and topical antimicrobial until you can get them to vascular and get new blood flow. So all the fancy dressings in the world are not gonna help if it's an arterial ulcer. Normally you'll find them on the digits, the tops of the toes, in repetitive areas, or the shower emboli after procedures. You'll get the trash toes. That's what we call them, trash toes. So, basically, you pain them with betadine until you can reestablish blood flow.
What if it's a distal emboli and there's no reestablishing blood flow?
So basically, the body is going to demarcate that. You want to keep it dry. Betadine swabs. Once it does become moist, then you treat it with moist wound care, topical antimicrobial, and hope that it's going to, that you're not going to have to lose, or it doesn't get like a secondary infection in the digit where you end up with having to
So you don't just automatically amputate?
No,
Okay.
no. I have a couple of those that were trash extremities that I'll show that I've taken care of. This is an arterial ulcer, anterior shin, and it was someone who just didn't have the blood flow. So reestablished blood flow, and this went on to heal. Generally, these arterial ulcers have minimal exudate. They're very painful. They're either really painful or they can't feel it at all. So those are, it's like, which makes sense. So anyway, they're punched out generally, usually involve deeper structures. The wound beds are not very, they're just pale. And a lot of times they'll get the secondary infections. Or when you reestablish blood flow is when you get your secondary infection, because now the body's able to fight it. And then they swell up and they get really, the wounds become more moist, and all of a sudden they're just like, you made it worse. No, it's going to get better, it's just got to get through this phase. So. This is a patient that came through the Prairie system who ended up with infarcts, but ended up with transmetatarsal amputation. He's doing great, that person is, but he did lose transmets on both feet, and did end up with infection of the bone, underwent hyperbarics. He's doing well now. So arterial, once again, referring it on. We now have our PAD clinic here at Prairie, so if you have somebody who has arterial disease, there is a supervised walking program downstairs. Did you guys?
Mm-hmm.
Yep. So referring for that.
Is it Pasvant too that has it now?
They may. I don't know.
I think I got, or maybe Pana, one of the P ones. They have one too.
Oh,
I just got a letter about it.
yeah. So it's, get them moving. Get them moving. So like I said, manage the bile burden, control any of the underlying stuff. Smoking sensation, it's tough, but it's like, okay, you're going to lose this limb. You revascularize, but if you keep doing this, you're going to lose a limb. So that's just, I swear, it's just a speech all the time with this type of patient. and actually having them go get counseling. I've got a patient right now that's like, you know, you've got to get help to do this. And so she actually set herself up and is going to counseling to help her, you know, deal with all her medical issues and to try to quit smoking. And I'm like, you know, sometimes you just got to push them. Our venous disease, it's valvular incompetence or obstruction. Congenital malformations can be there. The veins are regurgitating. We see this with that, but also with the fluid overload in the system. It starts overwhelming the valves just from our CHF. So, classic signs, the gator region, basically where an alligator might bite you, or it's actually from our gate from the gastrocnemius, but the gator region. I tell the patients it's where the gator bites you when I refer to the term gator. Hemocenter staining, this is classic venous stasis disease. Work with these patients to reduce swelling and get them to the point where they're considering venous ablations if it's available to them. Some it's the deep venous and that we can't help them. Controlling skin hygiene, all of that's an issue. My favorite new thing right now, it's over the counter, that's what was the grease, is this Eucerin 5. It's in German, because this is where the company is from, is Germany. But when I was doing my research for this program, I came across this product for proper pH, and it's pH 5, and our skin pH is the, 4.4 to 5, and so by using this, but we're using it in the clinic, and it just takes off this dermal scaling without causing pain, discomfort. We put it on, let it soak for a little bit, put warm washcloth on them, and it just like, whoop, takes it all off.
Wow.
And it's been amazing. I've used it for that, for venous stasis dermatitis and radiation dermatitis, because they're very painful. And we used it, and the person's like, where do I get this from? This is so good, where do I get this? I'm like, I got it off Amazon.
And you have to clean that off if it's oily after you've done that? Do you have to clean that off?
This off?
Yeah, because it's oily?
Well, I put it in my box, and it leaked on the way over. Here's why
No,
it's oily.
I know, but
Yes,
I
we
mean-
clean that off.
Do you clean that off after
Was-
you put it on the wound?
We put it on, and then we wash it with just warm water.
Uh,
That's it. So moisturizer still stays on. Because it's properly pH balanced, you don't have to get it all the way off. The venous ulcers are irregular shaped, ruby red, large volumes generally of fluid. They can be, they usually present shallow, but then can go deeper. I've had them around the medial malleolus inferior. They'll go deep enough to where, because there's not a lot of tissue over the malleolus, so you can go full thickness pretty easily in that region. And we do have some that are full thickness, but most are the partial thickness. These people get cellulitis frequently. If you have somebody that's had like 2 episodes of cellulitis in a year, you got to look at, are their lymphatics and venous compromised, and what we need to do for these people, because they're going to eventually be that population that are having recurring ulcers in the gator region. I have seen one amputation that was a result of venous ulcers, venous stasis ulcers, and it was because of the compression therapy. They were wearing their garment too tight around the ankle, and it caused a sore in the anterior fossa that actually went to bone, and they lost their limb.
Wow.
So, say, things can lead. You say,
So what's your antibiotic of choice? They come in, I see this all the time. People come in, they have cellulitis on their legs, and I want to start treating them before I send them over.
In the community, most providers will use the Keflex. If they've already been on Keflex out there, I get the culture. They'll put them on Keflex with no culture.
Yeah, that's what it
You know, it's like, if you've got something, you got weepy, get the culture. See what you got, you know? Then I use a lot of, it depends. I get the culture and I see what it is. I will treat topically.
is.
I would put Silvadine on that person, and wrap them in just something really light to absorb, and use Silvadene if they're not allergic, until I can get a culture back and know what I've got and start treating them aggressively. But usually it's Keflex is the first line I see people coming in on, because
So
usually
I'll
when
get 'em
I'm
a
getting
culture,
them,
then I'll give them Keflex, and then I send them to you.
yeah, yeah. And then we see whether or not, oh, I need to change it to something stronger.
Mhm.
If I have to go stronger, usually I'm into the I'll do doxycycline, the twice a day. I try not to get into the Cipros or the Levaquin. I try not to do that. I'll do clindamycin. If it's a diabetic foot ulcer, I might do Augmentin for a diabetic foot ulcer, and then I usually will use an Iotaflex on a diabetic if they don't have thyroid problems. So I'll use something topically, and then I'll give them Augmentin until I get the culture back. And those are, yeah, I will use Bactrim too, but I usually have to look at in that population I'm seeing, their kidney function and Bactrim, and usually the population that we're seeing is they're on Coumadin, and it just trashes their,
Right.
I know,
Their options.
yeah, it really does.
That's why Keflex is the favorite.
It's why Keflex is the favorite, but doxycycline and Coumadin you don't seem to see as much of a shift. So I have it. And the other one that I will use is the dicloxacillin. I'll use dicloxacillin as well. So anything that's oxacillin sensitive, I will choose dicloxacillin as my choice. The venous treatment is compression, and there's just a plethora of compression garments. The biggest thing out there is compliance for the patients, ease of use. So, and then the lymphedema, it's whether we have congenital defects, if they have lymph nodes, if they have radiation to the areas, incompetent valves. Getting them into the compression therapy is key, and getting them to wear the compression. When they're at these stages, stage 3 lymphedema, we're not going to change that. We might be able to contain it some, prevent them from getting reoccurring cellulitis. It's a management issue. These are the people that I have a just-in-case script out there for them, that if they start having prodromal symptoms, they are having a headache and general aches and pains and, a headache. It's like, those are their, what we call prodromal symptoms before they come down with their raging cellulitis that can go systemic within 24 hours on that patient. So if they're having prodromal symptoms, I'm like, you need to be on your antibiotic, and then it's not, their legs are going. So that patient population, it's nice to have them connected to an ID doctor who will keep them, kind of in check. And then put them in custom garments if you can. Pray they've got a caregiver that loves them enough to wrap them. And that's how we treat those. 20 to 23% of the patients have wounds that are complex. They don't look that bad, but these people are the hardest people to treat in our clinic. The first patient on the top corner couldn't get his ulcer to heal, couldn't get to heal. He had a venous ulcer due to the hydroxyurea drug. And he had the blood dyscrasia, leukemia, and so I got a hold of his oncologist, and we changed his drugs up. And he started showing signs of healing and healed up. And he's like, I've been all over the place and nobody said it was hydroxyurea. I'm like, I had 3 other cases, that's the only reason I knew. So, and then the next one down is on the left is the Levjoid factor 5 disorder. They'll get ulcerations. So the vasculopathy and vasculitis, those autoimmune ulcers are very difficult. The one on the far right is related to scleroderma ulceration. We see the pyoderma gangrenosums, we see calciphylaxis ulcers, and those are those ones that's just like, it comes in and you're just like, this just doesn't look right. Doesn't look right. So we do punch biopsies. We'll do a punch biopsy, and that's how you figure out what you got going on. Or you'll do the laboratory testing for autoimmune, and then the prothrombin time. And the test for those, it's just like, I just threw them up there, so you're like, oh, I think this person might have So there's just a whole host of possibilities of testing. And when I start getting into this type of wound, I'm like, okay, Dr. Karana, you need to look at this with me. Or, you know, the other day he pulled me in and said, Nancy, look at this. I think this is this. And I'm like, I think you're right. And he biopsied and it was a vasculitic ulcer. You know, it's just like you start practicing with your gut down there. So it's like, this doesn't look right. So you do it, if in doubt, biopsy. We do that. We don't do children in the wound clinic. This is a photo from a previous, but it was only my best second-degree burn I had. So I brought it in. Child touched hands on the stove. So conservative treatment, zero form, and gauze and wrap it up so no one could get to it. And that's still practice. I will also do Silvadene, but because this one was under the age of 2, I didn't do Silvadene. We just did the zero form in gauze. This is a traumatic injury, road rash, and you can get some pretty deep road rash out there. I treat it like a burn. Those we will see in the clinic. And so that was a Silvadene. This is a young boy that I treated prior to coming here. But this is gasoline fire, and this is a deep third or a partial third degree. Silvadene was the treatment in mechanical debridement. All of that slough. So this was more partial. This was where it was deep. And that took weeks for us to be able to lift that off, and it was just too painful for him to, you know, but it wasn't big enough to go to the burn unit. He went to the ER and was released home, but needed somewhere for care. So I worked with physical therapy on that case. This was one of my worst burns, and it was from a water bottle, hot water bottle on a back. And it was a young individual, 24 years old.
Wow.
Hot water bottle on the back. And it took forever to get
Like
that to
he
heal.
used it to
Like for
relieve
heat?
pain or something?
Yeah, he had felt like he had a pulled muscle
Oh
in the
my
back,
gosh.
got on this hot water bottle,
Oh,
fell
just
asleep.
burned himself.
fell asleep. He fell asleep with it.
Oh my gosh. Wow.
And that's what we ended up with. I was like, oh my gosh, I couldn't believe it. I couldn't believe it. 'Cause 24, young, I'm like, why could, because I fell asleep.
Wow.
The radiation is graded. This is a radiation burn that we had in the clinic. They do utilize us down there for those. Those are the grading systems for that. We are seeing more radiation now that our radiation, we've got more radiation doctors, and we're seeing more radiation skin issues, and they're referring them early to us, so I'm thankful for that. This is a patient of ours and a patient of Prairie's. He just recently had a heart procedure, but had radiation and had ulcerations at the trach, and you probably know that. Radiation
He's still
damage.
in the hospital, right?
Yeah,
Yeah.
yeah, and now he is developing the complications of radiation to the neck, and that is facial lymphedema. So we worked with him and made a facial mask and wrapping his head and stuff. It hurts his ears because the swelling gets in the ears and causes ear pain.
Oh, man.
But anyway, this was my patient that I used my Eucerin on, and they went out and got some of that because it was just, this whole neck was just sloughing. And then we used silver foam underneath the trach to help keep the bacteria load down because we had radiation burn, plus the trach drainage, and an ulcer there at the trach. And I think now that's, he's got like a little, almost like a hypergranulated scar in the area close to his trach now from where it had ulcerated and kind of overgrown, but it has epithelium over it, so it fits. I'm not gonna do anything different to it. This is a patient that we currently have. I referred to plastics, but she presented to me with just this little spot that had been opened up back and forth for 15 years. I'm like, another one of those, this doesn't look right. Actually, it probed to bone to the rib, and it was a lady who'd had a radical mastectomy, had the radiation therapy, and this is just scar. She can hardly lift her arm up, and that's all scarred down. So referred her to infectious disease. She ended up on IV antibiotics. They did a chest wall reconstruction, the flap failed. So she's back now with us with open, half the flap is gone. Maylee's gonna take her back in and do reconstruction again. She qualifies for hyperbaric. I started working her up for hyperbaric from the very first moment I saw her. And then I talked with Maylee and I'm like, we really need to do if you're gonna go back and do this flap again, we need 10 treatments of HBO before, and then finish out therapy afterwards to try to save the flap. Because all of it is radiated damage all the way into bone. It's gonna be very hard. The tissue is not good and vascular, it's just all scarring. So this is a very challenging case that we're working with right now. So it happens here. So pH 4 to 5.5. You think, oh, wash with an antimicrobial soap, and then Dove has pH at 10, Irish Spring 7.5, Dial 9.5. So we're drying their skin out too much. It increases their risk for secondary wound infections, actually. So if you think, oh, you need to wash with a good antimicrobial soap, rethink that. Rethink that. The solution to pollution is dilution, so maybe get a better pH soap and just have them do it more often. So clean it more often, but with a pH balanced soap. So your Cetaphil is fairly close to a good pH. The Eucerin is pH at 5. And our hospital Alavesta foaming cleanser that they have that doesn't have to be rinsed off is at 5.5. So right where we need to be. So just when you're ordering stuff, think about that. And then the plethora of products that I would use with my radiation or my stasis dermatitis, those are all things that I use. The Safe Tech is that silver foam. Now, if they're actively getting radiation treatments, they cannot have any silver product, any aluminum, anything like that. It intensifies the radiation, so that has to go away. Also, if you're ordering an X-ray or MRI, no silver can be on that either, or aluminum, or the neuropathic ulcers. Make sure you're, again, once identifying the type of etiology of the wound. This is a person who had neuropathy, but more from being an alcoholic. Their feet were cold and put them on a little heater, one of those little radiated heaters, and ended up burning the toes full thickness. So it was neuropathic ulcer, but not due to diabetes, but other neuromotor issues. So they need to be referred to make sure it isn't a vascular issue. Usually it's topical therapy, offloading. These people have really difficult time with pain management in those neuropathic wounds. Sharps debridement. We do sharps debridement in the clinic. My favorite tools, with me. Everybody kind of has their favorites, and all the nurses begin to kind of get used to what everybody likes. But one of my favorite instruments is the curette. It is a very nice, and we get these little bitty tiny curettes down there. And then my tissue nippers, the 15 blade if I have to do much deep debridement or callus debridement. In wound bed preparation, if you've got more than 25% devitalized tissue coagulum on the wound, you're going to want to be doing sharps debridement. Sharps debridement helps to stimulate wound healing. It resets the wound, saying, oh, it's acute. It brings the blood into it, blood cascade, we get the clotting factor, all of that. So serial debridements weekly have shown in research to promote wound healing faster. This is just examples of the tissue nipper, the 15 blade, and a curette, and those are my wheel course for debridements. I don't like to do anything that's going to be if it's required for me to suture, I think it should go someplace else. So try not to have to do anything deep enough to suture. This is a patient with diabetic foot ulcers, limited resources. This is getting into the case studies. So for this individual, so I'll probably go ahead and do some show and tell here. For this individual, I used a topical antimicrobial, which is IotaFlex. It comes out like a putty. It stays in place, can be left in place for 3 days. I used offloading for this individual and cut out. So if the patient's walking, it's not going to, you see the orange putty? That's what this is. and put them in an offloading. I used their orthotic in their shoe and cut out. I had them for a few days in a offloading boot, a couple weeks. I floated it, and then I had a dressing over top of that just to secure it, and had him healed up in a short, I'd say 6-week course of offloading. He couldn't afford to go back and get new orthotics because his were, you only get them like once every 6 months. And so I created, utilizing this in his own shoes, I put this in his shoe and created offload for him. So I put this down first and put his own orthotic in, and he was able to maintain then without reoccurrence. This is another offloading device in the clinic where a person has a heel ulcer. So we pull out the hexagons in the back of the heel and then use a dressing to float the wounds. This is dermal skin substitutes used to promote wound healing. It helps jumpstart. Using the one on the left is an Apligraph, the one on the right is a Dermagraft. Here at the hospital, we have a whole multitude of grafts that we use, from what we call cadaver graft, human skin that's been donated. It's on the shelf. It doesn't have to be kept cryopreserved. The one on the left is still a cryopreserved, and so that's not one that we're using. It's just the maintenance of that is just so much harder. We don't have one of those freezers. The Apligraph is made from foreskin of infants. They took out like foreskin years and years ago and have been growing sheets of skin in a laboratory. They put them in these little discs, and then we'll use that. And it actually interacts and helps to pull in growth factors. So it's more of they're more interactive with the wound. It's not like we're contributing growth factors. We recruit basically our own growth factors to the wound. The only product that actually contributes a growth factor to a wound is Regranex, and that is only used for diabetics. It's about $800 a tube. It's about a little, but it does work. Research out there shows, though, over 3 tubes used on a patient, if they have a potential for cancer, there's increased risk for cancer in that person. So I've seen a decrease in the use of Regranex out there on the market just because of that cancer scare, and there is a black box warning on it. I will use it occasionally, just kind of get them jump started, and I don't like to go past 1 tube. This has been my practice. Diabetic ulcers are staged, or not, they're classified, graded in Wagner scales. This is a Wagner grade 3. You have to have a Wagner grade 3 to get in the hyperbaric chamber. So if you have a patient who has a Wagner grade 3 diabetic foot ulcer, that person automatically qualifies to get hyperbaric oxygen therapy. This is a mixed etiology. Person had arterial disease and diabetes. They also had really bad fungal nail. So we treat that with our topical wound management. This is a person that stepped on a nail, couldn't feel it, another diabetic, so it's, offloading. That wound had to be debrided, treat the infection, and then patient education. This is surgical site wound dehiscence. They've had a cancer removed from the groin lymphatic system, and that was just basically filling it and absorbing drainage. It was right over the femoral. We're not going to vac that. You'll end up going through it. The doctor wanted to vac it, and it was no, not doing it. You want to do it by yourself, you figure it out, but I am not going to be a part of that case. Not over the femoral. So this is a Payne Martin a full skin avulsion. So this would be considered Payne Martin 3. It was a laceration at home, treated with oral antibiotics. It actually sutured the deeper tissue, but that outer tissue sloughed off. So we treated that with a topical acrylic dressing, which these come in all different shapes and sizes. It's clear, it wicks, it absorbs, and you can put them on, leave them on as long as they'll stay on. My longest time on one of these was 2 weeks, and took it off and it was completely healed.
What's that called?
They're tegaderm acrylics.
Yeah, I remember that.
They're absorbent dressings.
It's got the absorbent.
Yep, you guys can open it up. It's got baby diaper technology between the layers.
Tad.
Huh?
Is that what we call Tads?
I don't know if you would call it a pad. And another trauma wound. This one we used an Endoform product. It's just a topical collagen. So goals for wound healing, you want to establish what's going on in the wound. If it's dry, you want to moisten it. If it's wet, you want to absorb it. If it's got deep cavity, you fill it. You want to protect it. You want to keep the wound to the constant temperature. If it needs debrided, you've got your options for enzymatic, surgical, autolytic, where the body, you keep a moist environment, the body takes care of it itself. If there's swelling, you compress it. If it's infection, you treat it. You can treat topically. If it's not a systemic infection, if they're running fever, have a white count, you're going to treat systemically. So barriers, the frequency of the dressing change tends to be a barrier. So what they did a survey, 53% people lack of resources and time, and I see that the most. People don't have the resources, reimbursement isn't covered, it's not been documented correctly. You need a foam dressing to do the best for the wound, but the doctor wrote, or the nurse wrote, or someone wrote in the records, small amount of drainage. Small amount of drainage won't equal a foam dressing. You have to have moderate to large amount of drainage. So there's just all these requirements in documentation to get what you need for, am I doing okay on time? I'm
Yeah,
getting-
you're doing great.
to get what you need. People not having the correct experience, so they tend to not do what you're asking them to do. They just haven't got, they're not educated well enough to do it. Maybe they can't learn. They don't see the benefit of it. There's maybe a lack of guideline out there for what really needs to be done. Trying to keep our practice consistent in the clinic is part of what I do. So I'm going and I'm talking to the doctors, okay, this is what we do for this. This is the product we want to use for this. It's not that I want to tell them what product to use, but there's sometimes, this is the standard. This is what we need to be doing. This is why I'm going to the conferences and learning about what the new technology is and the dressings and the contraindications. There's times that, like, the doctor wanted to use a vac on, you know, a wound that's right over a femoral. It's like not good, you know. No, we don't want to do that. So sometimes we just have to educate. Budgetary issues, products that maybe I would like to use, they're not either on formulary here, it's too costly to use them in the clinic. And then fear of negative reactions. I had that with my own husband. He did not want to wear after his surgery and stuff, because he was getting some lymphedema. He didn't want to be in this big, you know, lymphedema wrap from the foot up to the top of the thigh. He didn't like it. He didn't want it. It didn't look as good. I'm like, are you kidding me? This is what I do. This is what I do. So I ordered him one of these.
Sexy socks.
I got him some sexy socks and a compression thigh sleeve.
Now he looks like Darth Vader.
And he's out walking around with his shorts on again, and lymphedema's better managed. So anyway, so the fear of that is true. And I wouldn't have thought I would have saw
Where do you get
that.
those?
Actually, Amazon's my new friend. Actually, I got them on, I got these from compressionguru.com.
Uh-huh.
And I went on there, and they are an athletic compression 30 to 40 sock.
30 to 40?
30 to 40 sock, and then you add your sleeve on top of them, and it provides that support all the way up.
Wow.
And this is another one. I got him in another color just because I thought, oh, he might like
Some variety.
variety.
See mine? But these are only 15.
So these are
Thank you. There.
these are from Jobs, and they're only a 15 to 20.
That's what these are, and I get 6 pair for $30 on Amazon. Dr.
Yeah.
Motion.
Yep.
Dr. Motion.
Dr. Motion.
Yeah. So this is an ulcer care kit that we use for our venous leg ulcers. The patient has to have, so if you have somebody and they're thinking, oh, we need to have them in compression, they're like, oh, we can't afford them. If they have an open wound, it's covered. So an open wound, I can get them in compression, but the wound has to be open. We have to document it. It has to have moderate amount of drainage. And So,
So we just need, so if I have somebody that has a wound and I wanna get them compression stockings,
yep,
and it's not like, something they need to be sent to the wound clinic for necessarily. So I would document that they have a wound, an open wound.
Yep.
It has moderate drainage.
moderate amount of drainage, yep, and they need compression. This is a 2-layer compression kit. I believe Sigvaris makes this one, or it might be Medi. Let me see, there's so many companies out there. This is a Medivan dual layer compression, and it is a 30 to 40, well, this outer sock is 20 to 30, but the under one, by adding the 2 socks together, it gets you the 30 to 40, so Medicare will only pay for a 30 to 40 compression. So you order this 2-layer system, and patients then can get them on. Because there's the first one, which is the liner, and then they put this one on.
So what's the toe pressure requirement for compression? Like,
It's the ABI, it's not, we don't go by the toe
we
pressure.
don't go by the toe?
No, so if they have a normal ABI, so 1 is normal, I compress at 0.8, I've compressed all the way down lower than that, but it's coming in a couple times a week, monitoring, making sure they're tolerating and that they're not insensate.
So anybody you put in compression, we have to do an ABI first?
You want an ABI. You could do a bedside screening and get an ABI. You can get an idea of where they're at. I will do bedside screenings. Put the blood pressure cuff on, pump them up, you compare the arm and the leg, and you're gonna get just a basic, you're not gonna get waveforms, that type of thing. But you can get a basic ABI at the bedside with doing the blood pressure cuffs. And you have to have the old blood pressure cuff, and you use the Doppler, and you use the Doppler on the arm as well, and you divide the ankle by the brachial, and you've got your ABI.
How much compression is the Ted hose in the hospital?
Those are between 12 and 15,
Okay. So we
and
don't
those are
have to-
for bedridden people, not ambulatory.
Well, we do them on all of our post-surgicals for a little while,
I
and
know,
that's not something we should be doing.
I know.
So
My
stop it.
concern,
Talk afterwards.
my only concern with that is if they're on, pressors, and
Uh-huh.
what are we, what's their blood pressure? And are we perfusing? And are we squeezing those toes too much in that? And should we be looking at just using the pumps instead of that slick thing going on and off the heel? How much are they moving their heels? So that's when I start seeing heel issues with TED hose, is low pressures, TED hose, and shifting, because this is about all they're able to move, because they're like, that's all they get,
Yeah.
and their heels start getting sore. So it's like, for those people, should we not just have them in the pumps and that's it,
Yeah.
post-op? Would that be enough to prevent the DVT? Would it be better to have them in something that you wrap them in and then take it back off? Do they sleep in them all, because usually they're put in those and nobody wants to touch them.
Exactly.
Nobody wants to take them off, nobody does skincare, so nobody wants to touch it.
Yeah, it's a good thought.
So types of dressings, we kind of pass some around. The acrylic is the Tegaderm. The alginates are, some have been out there for a long time, so if you're wanting to absorb and wick, you're going to go with an alginate. The composite dressings are these ones where you're combining a couple different technologies. This Q-Desorb is one that just came through, so it's the baby diaper technology. It's crazy green color. They've made it be, if we got some water, this is just kind of a cool dressing in that it will really, you guys want to see it first and then we'll do the demo with the water. So we're combining silicone and hydrofiber, the foam dressings, which you'll see these. I like them. We try to make sure that we're getting dressings in that they're baby safe as well, because what we bring in on contract has to make sure that it's okay at the neonatal center as well. So the silicone dressings are safe there.
So should we be putting those dressings, you think, on people's heels that are just critically ill?
Yes.
On pressers? Just
Yes.
go ahead and put them on there like you
Yeah,
would, but
I would put them in,
I think so.
I would put them in a foam.
Yeah.
Yep.
Slap a little
Leave it
bit.
on for a week. There's no open area, you're protecting it, just, yeah, that would be great prevention. Alright, let's do that. So, I'm so excited when this came through the other day because we have some wounds that just drain so much. This is a very small dressing.
Can you move that white box?
Right in front of it.
I should probably have a towel.
Just pour it into that box, is what you said.
Oh, no, I
Oh.
wondered, because I couldn't see.
Oh, move the box. I thought you said you were using it to put it.
No, I couldn't see.
So it's got silicone on the outer rim to try to help, and just put just a little.
Ooh. I feel like it's a pad commercial.
Right.
You guys, it is. And it just, it will just start wicking
Huh.
and swelling
Okay, so-
and puffing. Well, it's not going very fast. Why is this one not going? It's all sitting there, guys.
So how can you change that then if it's draining a lot? I mean, when it looks too puffy?
Yeah, well, the one maybe he just had the special kind in the demo the other day, because me and his just. Same thing with OptiLock, which is, we do have OptiLocks here at the hospital. The baby diaper technology.
That's cool.
This one isn't doing like he said.
Are they temperature sensitive or something?
The water's
They work
really
a little
cold.
bit better when
Mm.
it's warm, like,
Body
I don't
temperature.
know, but
maybe.
that one sure took it in.
yeah.
The other day his just puffed up like really nice.
Yeah, you're right, I bet it's warm water.
It's,
The
yeah, 'cause this is
warmer.
ice, this is really cold.
Yeah.
Maybe so. Maybe so.
And that's
So
nice cold.
our silver alginates, we'll just wick it up with that. So wicking your silver alginates, plain alginate. So silver you're gonna use when you want topical antimicrobial. So if you got somebody with cellulitis in the hospital and you need something, so a silver alginate plus the wrap, or you just call Woundostomy and they'll just take care of it for you. This is something I use in the outpatient clinic. I have to order it in a special, but it's a heel cup.
Oh, yeah.
Oh, nice.
I will put these on my amputations.
Mm.
I'll put them on the transmets to give them padding. When we're wrapping them, I use it on elbows and heels. But it's a nice,
It's reusable.
it is reusable. It doesn't have any adhesive on it, so it's something I'm putting in and then usually wrapping on top of it. Yeah. So then we have the Cedar negative pressure wound therapy. We have hydrogels, we have wound fillers. Wound filler that we brought in was silver powder. And then I have I didn't grab the tube this morning, but I also have a collagen powder. So if you're wanting to fill a narrow tunnel or something, the powders are the way to go. If you can't get something packed in, squirting it with powder is a nice option. We've got the multi-layer wraps. The one thing I do really want to caution on is inpatient and use of ACE wraps. Opt for the Comprelon short stretch when you can. The ACE wraps, they just bind. I mean, it's a binding and you don't get a nice, it's a circular, they can put them way too tight or they make them so loose that they're really not functional. So with the short stretch, there's not a lot of stretch. You get containment and then you have it goes this way and this way in the product. Your stretch does. So you don't get this where it can just keep going. They can cinch somebody down so tight with one of these that you can compromise circulation so much quicker with an ACE wrap than what you do with this. So with this, the nurses on the in-house side have a stockinette netting. They usually lay that down first, can roll with this. If there's somebody that's having a lot of drainage, they can put the SurePress padding or the Salona padding down and then wrap this on top of it. And you get a little nicer containment, a more even push of fluid, so you don't end up with this rope
Yeah,
look on the leg where it's all right around the ankle. But these have to be taken down and put back on every day. You know, they can't just put it on and leave it for the full week.
What was that wrap called again? I'm sorry,
Comprelon short stretch. It's a short stretch wrap. Comprelon short stretch. The old Econopace, that's what we have at the hospital. The Uniboot, we still use Uniboot. I will use Uniboot for that one slide where the guy had the really bad weepy stasis dermatitis, my favorite. I'll use that. A little steroid cream and an Uniboot. And then I will use the 2-layer Comprelon. This is a nice foam padding that will protect the bony prominences, and it wicks and absorbs. You get a short stretch effect with this bandage. So your short stretch comes from that, and the circular stretch comes from this. So an
this
ace
is for what?
for venous ulcers,
Okay.
lymphedema,
Uh-huh.
all of that. It can stay in place for a full week.
Oh, nice.
Yeah. So when you combine a dressing that will wick and absorb underneath, still maintains your moisture at your ulcer, and then you maintain and contain their edema with that, you can get, so it's decreased frequency of dressing change, increased compliance. I usually then also recommend the patient go by CVS or Walgreens somewhere and pick up a cast boot, and it is that plastic boot that comes up and seals around the knee so they can take a shower. And that increases. It's $25.
So for the patients that we see in clinic, like massive lymphedema, saw one yesterday, and
Who are they following with? That's, who are you following with for your swelling in your
Right.
legs?
right, nobody, of course. Looks like she's on the brink of gonna have some cellulitis. Just got out of a nursing home, but still, nobody's compressing her at all. So,
Those are the people that need to be referred.
and
So
they,
just go
and you
ahead and
could,
refer
you
them
could put them
over. Refer those
in, because they won't put a sock on, So,
They won't.
yeah, someone
And
told
bend
me
down
5
and
years
do
ago
it.
I needed to wear socks. They won't do
Take
it.
this off.
So
Right.
you could put this on them once a week, or teach the family how to put it on them once a week.
We put that on them, and then we work toward getting them into generally the Velcro systems that we can get. These will come to where you can get them custom made for them, or it's the ready fit where it's one that we custom make for them and snip it as they decrease in size. So those are out there too. They've recently just upgraded systems in these Velcro systems, and they have to have open wounds to get these covered.
Is that what's called a circade?
This is considered a circade. They just came out, Faro just came out, so people hate these because they can't get them on, they don't stay, I can't reach down there, and they're big old bellies and they're trying to reach down and get there, they can't do it. So the company got smart and they added a downing sleeve to it. So now the person pulls it up the leg, and then they can start doing their Velcroing, and it's not
So
going
it's not
anywhere.
falling off. like-
It's not falling off.
Oh, yeah.
It's like, oh, this is so smart.
Yeah.
Brilliant.
Improving some technology. So I have ordered several of these styles. So 2 different companies make this style, and so either one are performing, and it's whatever I can get their insurance to cover. And the patients are like, oh my gosh, I've had the other kind. This is so much better. It's so much easier to get on, and they're willing to use it. And if you can convince them, then their $75 doesn't seem that bad, because this is $75 over at the home services, Bono's and the other place here in town. They're charging $120 for these. It's $77 online. So I'm like, well, you can get it online.
And they're called, what's that called then?
This one's a Faro 4000, Faro 400, it's a Faro wrap 400, the Faro 400. but it's a Farrow, and it has the liner in it.
Farrow.
Yeah, it has it, and then, they have it, and Compraflex has it. Compraflex Light has them as well. This one here is the old Circade. So it's made, I believe Medi makes the Circade. What else we got? We're running out of time. That's just another description of, you know, what you're looking for. If you've got moderate, your goals for wound care and the dressing that kind of connects to it. And then these are just cases that, post-op cases that would be a back dressing. This one, I used the topical silver powder on this because I just had weeping on the staple line. I just needed to compress it, topical antimicrobial, and it went on to heal. This one was back. It was a patient fell and on Coumadin therapy and huge hematoma to the knee, and treated it with a back dressing. This is another hematoma. Coumadin is not our people's friend when they fall. One of my worst wounds out there was the pizza box fell out of the freezer. The corner just hit her right on the shin. Huge hematoma. And then I've had other people, car doors. They come in, they got that bumped up area in the hematoma, and if you start seeing that top layer of skin is purple, that wound is going to necrose down. It's better just to refer them. And I get these usually between 6 and 8 weeks that they've had this.
Oh my God.
It's like it hurts so bad. I'm just like, yeah, get the hematoma out. You know, after, you know, a couple of weeks, if that hematoma is still sitting up there and you're starting to see it, the tissue go dark, it's dead. There's been so much blood in between. We've had interruption in that surface perfusion. The tissue's necrosing. And so,
How far along can you still get the hematoma out?
these are like 8 weeks. I
Really?
mean, they'll come in and they've still got this bump, and I will numb them up and open it, and it's just like squish, and all this big clot comes out. It's old clot. And usually we don't get them to that point until, it looks infected, so then they need to go see somebody. I think if we would take out the clots earlier, I wouldn't end up with these really bad, you
That's
know.
what happened to my grandma in Eliquis, and they ended up having a skin graft her entire upper leg knee.
You know, when they leave them in, I think it's like I think after a couple weeks, that initial bleed should be done. We need to get in there and get that clot out of there and start wound healing. That's my spiel. This one had a dehiscence, so it was antimicrobial packing, and went on to, didn't have to have the knee taken out. I mean, it went on to heal and it did fine. This is individual that hit on a cinder block all the way down to tendon, and we were able to get them healed up with enzyme. It took several weeks on this one to get it healed up. They did not want to do a skin graft. The person just didn't want to have to do a skin graft to get it healed up, and we were able to get them healed up with topical antimicrobials, and we had it healed at 14 weeks.
It's incredible.
So,
Yeah.
yeah.
Can hardly even see
Scar's
it.
not even that
Yeah.
bad.
So, anyway, so talked about the different types of wounds. Etiology should, the etiology of the wound should drive your treatment plan. Okay? Eliminating barriers where you can, and selecting products that will be easy for the patient or the caregivers to do. And then you always have to consider the cost. And the barriers to care, the main one is cost of product.
Is there any time that you leave things open to air? Is there, I mean, do you give people a break from the adhesives and, you know, just, I don't know, just always
Just
thought that
shower,
was.
dry it off and put the dressing back on.
Do you don't let it dry for a couple hours and then put the dressing back on? Is there any
No.
benefit to that?
No, we do have a person who's in a vac, and we'll take the vac off and let him dry we'll take it all the way off and let him dry while he's in the chamber, just because he gets maceration around the wound edges. But we put the vac back on as soon as he's out. So generally, no, but what we try to do then is provide barriers. So we'll use, there's the old product Duoderm, it's a hydrocolloid. We will use a hydrocolloid ring right up to the wound edge, so it protects that skin from moisture. And so we make just adjustments in the treatment plan and in our dressing procedure to protect the wound edges and to absorb moisture when we have stuff like that. So we keep the wound bed moist. The wound needs to stay moist, but it doesn't need to be saturated. So if it's saturated, we have to change our product. And so we go to a more highly absorptive dressing to absorb.
Probably like a wound in a healthy person that's gonna scab over or something, that's what you would, or a
Right.
small, you know, not like a deep something.
But
where-
even a wound in a healthy person, with a dressing, even an over-the-counter like my Band-Aid that I'm wearing, I'm keeping my wound moist. I'm gonna heal faster because it takes, when a wound dries out, it takes longer for the epithelial cells to migrate across the bed of the wound.
Oh, okay.
A scab, the epithelium has to migrate under and across. So if the wound is just completely moist, then it can just keep right on going.
Huh.
If the wound is dried out, then the scab comes off because the epidermis has had to burrow under, cell by cell, jump over itself to go across that scab,
So keeping
under
it-
the underneath side.
So if I scrape my knee, I should keep a dressing on it to keep it
I
moist.
really like
Yes.
scabs.
Yeah, right.
Yeah,
That's good to know. Okay.
yeah.
Well, now we know.
Oh, yeah, I thought dry to heal. No.
Yeah.
It looks
The only
better when
place
it's
I
dry.
want to dry.
Yeah, it does.
The only time I recommend drying anything is under the breast and in the groins. And then I will add the powders in the inner dry. And my favorite, when these people come in and they're just yeasted and they're from home, it's like, okay, get yourself a little acetic acid, little home vinegar, put it in some water, in a little spritzer, and spray it under the breast and lay on the bed for like 10 minutes and then get up and do your shower.
Good. One of your nurses in the hospital taught me that like a couple of years ago.
Uh-huh.
Because, you know, I'm known now as like the queen of the groin. Anytime you have a big illness,
You gotta
the
look at
docs
the-
want me in there like, Jenny, fix this so we can do their procedure. So, but she taught me that, and I,
Yeah,
so
acetic
I've been
acid.
telling them to do it 3 times a day
You can,
to clean it
yeah.
with the sprayer. And the,
Queen of the Painless. That's
Yeah.
that's a great title.
I know.
And then,
Do you remember in the meeting even last week? They're like, yeah, Jenny looked at that groin, so
So
it's handled.
it's the acetic acid, the inner dry.
Okay.
I will use the 2% miconazole powder and the silver powder. On those really rough ones, I'll add the silver component to the miconazole, so you get your antimicrobial and the fungal
Nice.
in the groin. All my little tricks.
And not apple cider vinegar.
I have people do both. It might burn more, maybe the apple cider vinegar might burn more, but just regular vinegar, just the same, it's the same thing you use, it's the quarter strength acetic acid is what you use. Yeah. just
Witch hazel, like a. is that
Witch
acetic
hazel
acid?
dries, that helps with itching.
Uh-huh.
um,
Mouth or something like that.